Hello. Magandang umaga po. I'm Patrick Eustaquio. Probably a year ago, ako po yung nagsasagot ng pre-test post-test as part of SHIP HTTP. I think I was part of batch 3 or batch 2, I'm not sure. But I'm always part of SHIP's capacity building activities because I always find it helpful. So I'm happy na participant pa rin ako ngayon. It's just I am sharing what I've learned throughout all of the sessions I've had with SHIP. So happy Pride Month. It's June. So we're celebrating lots of wonderful things this month. So siguro we can probably start. Siguro let's just start with a case that will make you think of our things that we have to talk about today. So we have a client, 12 hours prior to consult, MC. We have our patient, MC, a 23-year-old male, had a condom-less intercourse with a male partner who eventually informed him about a recent seroconversion as HIV positive and not being on ART yet. So MC's last sexual encounter was 6 months prior to consult, and he was HIV negative 3 months ago. He disclosed on and off injecting with cocaine with last episode 4 months prior to consult. So what is the best HIV prevention option for our client? So if you would want to share your answers, pwede po sa chat. No? So I would give you around 20 seconds to think about the case and kung ano po yung sa tingin yung best prevention option for our client. So is it A, PEP, B, HIV testing, C, providing clean syringe, D, counseling, or E, all of the above. So yeah, I'll give you 10 seconds more. So thank you po sa ating mga nagpa-participate. So yeah, so I think we could probably reveal the right answer. No? So, well, the point of this question is technically tama naman tayo lahat. Nakita ko yung mga sagot natin sa chat. So we're all correct. But the best answer here is all of the above. So pwedeng PEP kasi very recent yung exposure, 12 hours. HIV testing, of course, kasi matagal na siyang hindi na-test. Clean syringe kasi the patient is injecting the drugs. Tapos counseling, of course, will always be there. So the best answer, tama tayong lahat, the best answer is definitely all of the above. Right. So ito, this is just a framework of what we call yung combination prevention. When we talk about HIV prevention, it's always this framework that comes out. So this is from the Pan American Health Organization, which tells us that there is no one size that fits all in HIV prevention. So HIV prevention is always composed of 3 aspects. So biomedical, behavioral, and structural. So what we're talking about here, yung mga nakabox, no? So which is PrEP and PEP, counseling on risk reduction. So dito natin mapapansin, no, that those topics are just the tip of the iceberg. There are lots of other things that we have in our toolbox to prevent HIV. Okay, so let's start muna with PrEP or pre-exposure prophylaxis. So PrEP is it is the use of antiretroviral therapy among HIV-negative individuals to decrease the chances of acquisition of HIV infection. So I'm sure in your earlier courses or in your earlier sessions with HTTP, you came across the life cycle of HIV. So alam na natin yung pagpasok ng HIV sa katawan would need lots of mechanism. And one of the mechanism here is yung reverse transcriptase. So what PrEP does is it inhibits reverse transcriptase, which HIV uses to live and replicate inside the body. So we have 2 forms, one of which is available in the Philippines is yung oral form. Now, so this is emtricitabine, tenofovir, disoproxil fumarate. Yung other one, tenofovir, alafenamide, hindi pa siya, I think, available sa Philippines. And yung injectable cabotegravir. So yung cabotegravir was recently approved by the US FDA for use. So this is just a single, this is an injectable, no? Tapos, single ARV lang siya compared with the oral, which uses two. Okay, so ito yung evidence na which informed the WHO guidelines. We will not go into the weeds of it. Kasi we all do know that it really works. But if you come to look at it, this is just a systematic review and meta-analysis of all of the 16 studies that have been done, comparing yung PrEP with placebo, PrEP with no or delayed PrEP, tsaka observational studies. So across all of the studies, across all of the types of studies, PrEP definitely decreases the risk. And another key point here is that, as we can see on the figure on the right, very important yung adherence ng ating clients to PrEP. Kasi if mataas yung adherence, mas mataas yung risk reduction or yung pagbaba ng risk of acquiring HIV. So it may be overwhelming yung table and yung graph, but it just tells us that it really works. So if we look at individual studies, which may be more feasible for us to digest, so there are lots of studies, international and of course locally, that proves the efficacy of PrEP. So yung IPREC study in 2012 has shown 99% protection if taken as prescribed daily. Yung IPREX OLE study in 2014, 100% protection if taken at least 4 out of 7 days. 84% if taken 2 to 3 times a week. So kahit hindi optimal yung adherence ng ating clients, mataas pa rin yung protection. But it doesn't mean that we can it doesn't mean na hindi important yung adherence. Important pa rin siya. Pero it does work, even though may problems with adherence. Tapos PrEP in the Philippines, which was a demonstration study in Love Yourself in the Philippines, no new infection among their cohort of MSM and transgender women. And I just put here yung systematic review or yung meta-analysis of the risk reduction among doon sa correct and consistent condom use, which is 91%. So we can see here definitely na at par yung dalawang interventions na yon, yung PrEP and condom use. Tapos, yeah, so it's definitely best used together, as PrEP does not protect the individuals from other STIs. And I'm happy to see doon sa ating poll earlier na even though yung client natin may be undetectable na we still encourage the use of condoms. So it's very optimistic na we go for combination prevention as always. Okay, so here we can see the PrEP recommendations from the WHO and DOH. As we all know, the DOH released their guidelines for PrEP. So nakaka-happy kasi we finally have it. So WHO in 2016 said that oral PrEP containing tenofovir should be offered as an additional prevention choice for people at substantial risk of HIV infection as part of combination HIV prevention approaches. Meanwhile, yung DOH guidelines says the same thing. So individuals at substantial risk will benefit most from PrEP. So we always emphasize the use of term substantial risk because it destigmatizes, specific groups that we've always thought na at higher risk of HIV. And we will always base on local epidemiology and individual assessment rather than judging the risk group alone. Kasi we do know that across the world, different yung picture ng HIV epidemic. So it could be among heterosexuals, it could be among MSMs and transgender women. So ang important is looking at the risk of our clients. Okay, so what is substantial risk according to the DOH? No? So those who engage in, so ito yung isa sa mga questions na sa ating pretest. No? So substantial risk is are defined as follow. No? So those who engage in sex with the pill HIV who is not virally suppressed or whose results of viral load testing are unknown. Tapos in the past 6 months, those having condom-less anal or vaginal or neovaginal sex with more than one partner, those with history of STI, those who use sex-enhancing drugs or non-sterile injecting equipment, those who have used HIV PEP for sexual exposure, and those who have a sexual partner with one or more HIV risk factors, and lastly, those who requested PEP. Okay, so yung questions in the pretest, mapapansin natin, iniba-iba natin yung month sa choices, pero parati natin tandaan yung for the past 6 months. Tapos yung isa sa mga choices doon is pill HIV kasi it's not necessarily na lahat ng pill HIV, no? So, kasi kung virally suppressed naman and alam natin yung viral load, no? So, pwedeng hindi na substantial risk yung partner niya. Dahil, as we all know, U equals U or undetectable equals untransmittable actually has very solid evidence. No? Lately, talaga na parang parating messaging sa U equals U is less risk. No, it's not always zero risk. Pero now, organizations are really taking a strong message na there is no risk of infection. No, so ganun ka ganda yung evidence, no, so U equals U. So that's why very important to take note of that. Okay, so in terms of indications, we have clinical indications for PrEP. So the client should be HIV negative. The client should be free of signs and symptoms of acute retroviral syndrome with no probable recent exposure to HIV. So ano ba yung mga signs and symptoms ng acute retroviral syndrome or ARS? So these are very non-specific flu-like symptoms. Most common, greater than 70%, pwedeng fever, fatigue. More than half of the time, we have body malaria, arthralgias, headache, anorexia, or loss of appetite, rash, and night sweats. No, so very non-specific. No, it could be thought of as a flu or even COVID or any other viral infection. Pero very important to take note yung exposure. Tapos, the client should have a good renal function, creatinine clearance of greater than 60 ml per minute, free of any allergies or contraindications to tenofovir or to emtricitabine, and weighs at least 35 kilograms. So kung mapapansin natin dito, walang age, no? And yun yung very tricky sa ating PrEP guidelines. Kasi we all know naman na we can always give opportunities to those who have substantial risk regardless of age. So basta greater than 35 kilograms, no? And substantial risk. Okay, so in terms of initiation, so very important, syempre, yung counseling as always in any part of what we do. So, ang key messages based on the DOH guidelines is that PrEP is an additional method lang. Kasi we have other options such as condoms and risk reduction counseling and other components of combination prevention. And one more aspect of counseling is discerning whether PrEP is the right tool for the client. And then we definitely have essential laboratory tests and clinical evaluation. So we should have a very recent HIV test within 7 days. So if we have noted an exposure within 72 hours, we should offer PEP and retest after 28 days. If negative at repeat HIV test, we initiate PrEP without gap if with constant exposure. Tapos, serum creatinine, although it should not delay PrEP initiation unless there is suspicion of poor renal function or with pre-existing renal disease. Recent hepatitis B test, HBsAg, STI screening, either syndromic or etiological, hepatitis C for MSMs and PWID, and pregnancy tests. Kasi although PrEP can be safely continued, although definitely we have to still know whether the client is pregnant or not. Definitely, kasi we would need to have them as an additional counseling points because they're taking medications. Okay, so I'll skip this kasi naturo na daw ito ni Dr. Tripon sa inyo. But the DOH guidelines actually also includes also says that hepatitis B should be managed accordingly. Mataas ang hepatitis B prevalence din sa Philippines, no? So it's very important. Ang nakalagay lang sa PrEP guidelines na silipin yung isang hepatitis guidelines ng DOH din. So ito yun, naturo na din to ni Dr. Tripon. But generally, ang message is kailangan siyang i-co-manage. And being a primary care clinician, and I'm sure a lot of us here are primary care practitioners, nurses, doctors, social workers. I'm sure dahil sa universal healthcare, we're all slowly being trained for hepatitis as well. So it's very timely to know all of these. Okay, so in terms of dosing, sorry. So in terms of dosing, okay, sige. In terms of dosing, alam naman natin na it's emtricitabine 200 milligrams plus tenofovir 300 milligram 1 tab per dose. No? Tapos max dose is 2 tablets and can be taken with or without food. And there are 2 main ways of taking PrEP, daily and event-driven. So firstly is yung daily PrEP. It's given for clients who have periods of frequent or unpredictable sex. Tapos when we ask them or when we start or when we initiate them on PrEP, we should be able to set their expectations on PrEP. So these are very helpful information on how many days before we can reach the optimal efficacy for PEP. So for 5 to 7 days for anal intercourse, 20 days for vaginal intercourse. So in those days wherein we are still trying to reach the optimal efficacy, there should be additional prevention measures just in case. And then another option is event-driven or what we call 2-1-1. This is mostly for MSM with predictable or infrequent sex. The reason why it's just among MSM because the studies or the evidence that are available are still limited to MSM, but hopefully it would expand. So what we can do here, itong very helpful diagram here, it illustrates that 2-1-1 is being given in such a way that we give 2 tablets 2 to 24 hours before sex, and then the 3rd tablet 24 hours after the first dose, and then the 4th tablet 48 hours after the 2 pills. After the 2 first pills, no? So very helpful in the diagram na to be able to know how to take it properly. So if more sex acts takes place in the following days, single dose may be continued with 2 or more days of single dose after the last sex. So parang magiging daily na din siya, pero maganda kasi sa event-driven, no? They are more in control of their sexual practices, and they may even maximize all of the PrEP pills that they have. Okay, so in terms of follow-up, very important pa din definitely because nasa prevention cascade na sila. So magandang may regular HIV testing, magandang may regular counseling, no? So it's very important to follow them up at 1 month, to do HIV retesting, and to always screen for acute retroviral syndrome. And we should assess the side effects and adherence, drug dispensing, and addressing these issues. So every 3 months we have to provide them HIV testing. We have to offer them HIV testing, STI screening. Every 6 months, serum creatinine, unless with diabetes or hypertension or any other comorbidities without altering the kidneys. Notice every year, hepatitis C antibody screening for MSMs and PWID. So in terms of follow-up, in all follow-up visits, mas magandang may HIV testing and counseling. If the HIV test turns out to be inconclusive, we should stop PrEP for now and then retest after 14 days. May resume if repeat HIV test is negative. Tapos, if seroconverted to HIV positive, stop PrEP and late to care immediately. Send blood for drug resistance testing. I know that some of you may be wary of the risk of drug resistance, but studies show that the risk for drug resistance is just 0.1% of those among who use PrEP. And these are mostly among people who got their infection while initiating PrEP. So it's a very rare occurrence. So I'm sure it's a very common question, but yun yung very reassuring part of it. So 99.9% of the chance walang drug resistance. Tapos other key messages for counseling include yung PrEP dosing and side effects, the risk of sharing PrEP drugs with other people, very common. So kailangan aware sila kasi it affects their adherence. So yung adherence assessment, whether kulang yung number, this is primarily sa ating pharmacy, yung number of days on continuous intake, number of days on PrEP before and after the last possible HIV exposure, proper ways of storing PrEP, sexual health protection in terms of condom use, pregnancy, STI, alcohol, substance use, provision of other prevention commodities, mental health issues, mate partner violence, and always include reminders for clinic follow-ups if necessary. Okay, when patients want to stop PrEP, it can be stopped if they are no longer considered at substantial risk. However, if they are still at substantial risk and they want to stop PrEP, we may want to provide them or upscale other options for prevention. However, maganda ding mag-follow up with their clinician if they want to stop PrEP, especially if they have other comorbidities such as chronic hepatitis B, because we know it's not that easy co-managing with chronic hepatitis B. Okay. So now let's go to post-exposure prophylaxis. So makikita natin magkaiba yung prefix, no? So kanina pre, kasi before exposure, and now post kasi after exposure. Okay. So in this part of the discussion, we'll be mostly focusing on this will be yung discussion natin will be composed of many guidelines from many different organizations, not just the DOH, because the last DOH guidelines for PEP is very outdated, so 2009 pa. And the other one is very specific to CBS, in 2021, and very specific to percutaneous exposure. So this will be a mixture of different guidelines that I find helpful. So WHO, CDC, New York State Health Department, DOH. So this will be the sources of our discussion for PEP. So in 2016, the WHO recommended a PEP regimen with 2 ARV drugs. But they always say that 3 drugs are always preferred. So in terms of the preferred backbone, it's always preferably tenofovir and emtricitabine, or lamivudine. So very important. So sounds familiar, right? So ito yung regimen din ng PrEP. Pero may third siya na drug dapat nakasama. So ang recommendation ng WHO is dolutegravir as the third drug. So it could be atazanavir, darunavir, lopinavir, ritonavir, or raltegravir. Can be considered as an alternative third drug option. Pero what we use commonly in the Philippines for PEP, efavirenz, should only be given when there are no other options available. Okay, because there are lots of evidence that there is poor tolerance and very difficult in terms of adherence. So apart from the evidence and the studies, we also found this in our clinic work, wherein we always have to follow up patients on efavirenz, even though it's just 28 days. Okay, so when we talk about PEP, there are two types, so occupational and non-occupational. It usually depends on the exposure. For occupational PEP, these are all personnel working in the healthcare setting with exposure to HIV. Non-occupational PEP happened outside the healthcare setting, for example, community exposure, consensual sexual exposure, sexual assault, and needle sharing. No, so in some guidelines, hiwalay yung sexual assault na type ng PEP kasi very specific yung instance na yun. And we really have to know the urgency of such situation. But in this guide, but in the WHO guidelines, it's part of the non-occupational PEP. And when we talk about PEP, it's always helpful for us to know the different types of exposure and the corresponding risks, because this will help us decide whether the exposure is high risk or low risk. So this is one of our questions in our pre-test as well. So very helpful to know kung if, for example, our client was exposed to a particular type of exposure, this is how much risk the client may get. No? So very apparent yung blood transfusion, no, and even vertical transmission are very efficient ways of transmitting HIV, hence the very high acquisition rate per exposure. But at least what is relevant to us yung needle sharing among person who inject with drugs, no, it's always very high at 63 out of 10,000 exposures. Tapos we have percutaneous needle exposure or needle stick injuries, which is very high as well. Pero mataas pa din yung receptive anal intercourse. Kung i-compare mo to with kung insertive, no, it's always around 10 times higher the risk. So it's always receptive anal intercourse and then percutaneous and then yung other types of insertive. Dito natin makikita ng oral exposure, receptive man or insertive, have very low HIV acquisition. And then negligible yung biting, spitting, throwing body fluids, and even sharing sex toys. Very important to also note the factors increasing the risk of HIV transmission. So for example, the presence of other STIs, especially may mga ulcer, in the source or the exposed individual, may facilitate the transmission of HIV. And of course, yung U equals U, or yung plasma viral load of the source. In terms of evidence, compared to PrEP, the evidence of PrEP is very limited. Kasi it's they couldn't do it in randomized clinical trials. Otherwise, it is unethical to do so. So, in terms of efficacy, what they have known, it's always time dependent. Definitely. So, timing is key. So, less than 72 hours, dapat mabigay na natin yung PEP. So among 16 studies of outcome of HIV PEP, these are mostly among healthcare workers. There are low discontinuation rates because of an adverse event among those taking tenofovir and lamivudine. If we compare natin with zidovudine and lamivudine. Tapos yung darunavir and dolutegravir are associated with those with highest continuation rates, with lowest substitution or discontinuation due to adverse events. Whereas yung efavirenz have high rates of discontinuation and CNS or central nervous system events. So it could be well tolerated, pero the acceptability is very limited. So it's always the last choice dapat. Okay, so when it comes to PEP, kailangan natin malaman din yung standard of care. So this came from the WHO guidelines, and sorry, may strobe lights dito. So this came from the WHO PEP guidelines, and it is composed of four components: so assessment, counseling and support, prescription, and follow-up. So we will go through one of them, one by one. So in terms of assessment, I must say this is the most tricky part of providing PEP. So, teka lang. Yeah, thank you. So this is the most tricky part because this is always the most challenging one. So even me as a clinician before, I find it difficult sometimes to assess whether the client has to have PEP or not. No? But this helped me a lot to discern. Kasi nga iba-iba rin yung evidence, very limited yung evidence. No? So this came from the New York State Health Department guidelines on PEP. And specify na nila which ones yung mga exposures which wherein PEP is really recommended. And for example, this is when the source's HIV status is positive or unknown, and when there is receptive and insertive vaginal or anal intercourse, needle sharing, penetrating injury such as needle stick injury, which was exposed to blood and potentially infected fluids. Tapos if there is any bite with visible bleeding in the mouth that causes bleeding of the exposed individual. So parang through and through yung wound. And then next, these are lower risks wherein we look at other factors that increase the risk. So for example, in oral, vaginal and oral anal contact, whether receptive or insertive, or receptive and insertive penile oral contact with or without ejaculations. Very common among our patients. So we just always have to look at the factors that increase the risk. For example, the source is known to have HIV with high viral load, non-intact oral mucosa, for example, may oral lesions, gingivitis, or wounds. For example, may blood exposure, and the presence of genital ulcers. And other sexually transmitted infections. And meanwhile, we have these kinds of exposures wherein PEP is not really recommended. For example, kissing, oral-to-oral contact in the absence of mucosal damage, human bites not involving blood, exposure to solid-bore needles, mutual masturbation, and exposure to saliva, unless may visible blood. But when it comes to kissing, there's only a single case in 1990s that was associated with open mouth kissing, and no other cases have been reported. So the risk is very remote. Okay, in terms of assessment naman when it comes to PEP, so syempre kailangan natin tingnan yung eligibility. Our client should be HIV negative, who is potentially exposed. Tapos, dapat within 72 hours yung exposure. Infrequent, dapat yung high-risk exposure. Kasi otherwise, the patient might be better off with other prevention options. So, for example, and other kailangan din natin makita sa ating assessment yung mga baseline laboratory. So, the table in the right is a very helpful table to know which laboratories are needed. For example, for both the source and the exposed person. So for the exposed person, definitely we need to have HIV test, hepatitis test, STI testing, and serum creatinine and ALT/AST. So we need also to assess the source if available. So clinical and laboratory tests. Kailangan din natin i-test for STIs and HIV and hepatitis. Okay, so this is very important, yung first aid when it comes to PEP. So if percutaneous exposure, just allow it to bleed. Do not squeeze the site. Do not suck the wound, definitely. Immediately gently wash the site with running water, with mild soap. Don't use strong solutions such as alcohol, iodine, bleach. And then if fluid was splashed into unbroken skin, wash immediately with running water. Do not use strong solutions again. When there is exposure to the eye, irrigate the eyes with water or normal saline. If wearing contact lenses, put it as is. Don't remove it because it protects the eyes. Once it's cleaned, remove the contact lenses and just clean it as usual. Do not use soap or disinfectant in your eyes. Exposure of the mouth, spit the fluid immediately, rinse with water, repeat 5 times. Do not use soap or disinfectant, of course. And then lastly is on sexual assault. Isa sa mga first aid natin definitely is to refer them to ancillary services, may be legal services or mental health services that they may need, or OB-gynecology services as well. So, or any surgical services. So, kailangan natin makita yun. Okay. So, in terms of counseling and support, so this is just a checklist from one of the guidelines. No? So, ito yung mga key messages. So, there should be a sense of urgency of the situation. It should be understood by the patient. The likelihood of exposure and the risk of infection. The benefits and effectiveness, timing and duration of PEP. The purpose of HIV test and other tests and interpretation of the results. Implications if the source is HIV positive, follow-up and testing schedule and the purpose of it. And then we have to go into the specifics of PEP. For example, we got yung regimen itself, whether there are possible drug-drug interactions, dosing, or potential adverse effects, adherence, and what are to-dos when there are patients who have missed some doses. And signs and symptoms of acute HIV infection and what they would need to do in case this happens. Okay, so dun na tayo sa prescription part. So the preferred regimen is composed of a 2-ART backbone and the third drug. So tenofovir, reciproxyl fumarate, and lamivudine or emtricitabine. 1 tablet once a day. And the third drug, it could be dolutegravir, 50 milligram, 1 tablet a day, or lopinavir, ritonavir, or Raduvia, or efavirenz, if there is no other choice. No? So it should be taken for 28 days. The special consideration for ART regimens are still applicable. I'm sure you had a lecture already on the ARTs and their corresponding special considerations. For example, yung counseling among females of childbearing age, tapos yung antacids when you're taking TLD. So the common ART specific acute adverse effects are also applicable. Yung chronic adverse effects are not usually a concern because it's just taken in a short duration. Tapos usually reversible din yung mga chronic adverse side effects if they discontinue yung PEP. And then lastly is the drug interactions also apply. Okay, so very important yung follow-up, especially within 2 days and within 2 weeks. So in those times, pwede daw via call na lang, especially especially now that we have COVID, and even before, because it's just going to be quick, just to ask the patient how they're doing, especially in terms of adherence, and maganda rin mag-follow up in week 4 and week 12, just to make sure of the zero status of our patient. So at follow-ups, always assess for PEP adherence and look at the additional lab tests. Recommended lab tests are seen on the table on the right. If seroconverted, link to care as soon as possible. If repeat test is HIV negative, may start PrEP with continuous exposure. So makita natin on the table on the right, always constant yung HIV testing. Very important. Yung hepatitis, definitely after 6 months after exposure, both hepatitis C and hepatitis B. Yeah. And okay, so last, another tool in our combination prevention toolbox is the sexual risk reduction. And it is very important because we do all know, or we do realize that HIV transmission, or that behavior really plays a big part in HIV transmission. So here, very important kasi natin maintindihan yung behavior ng ating patients. So this is one of the theories that I always find helpful, the theory of planned behavior by Godin and Koch. So this tells us about the internal and external influences that make that lead to a particular behavior. So this is among the frameworks that I always find helpful because there is a component of the environment that they live in, not just on their impression or not just on their own. So very important dito yung norm na nakalagay sa second circle kasi very important din yung peer education. No? So sexual risk reduction is a part of the combination prevention and WHO recommendations. The evidence include yung mga to, no? So the comprehensive risk reduction counseling and services are associated with reduction in risky sexual behavior and HIV and STI incidents. No? The peer education increases the odds of HIV testing, condom use, reduce equipment sharing, condomless intercourse, consistent over and it was found to be consistent over 24 months. Kaya marami sa ating mga interventions in the Philippines are community-led, no, or peer-led. Kasi it's very sustainable and it's very effective among our vulnerable groups. However, common barriers include competing priorities, staff time, and limited financial resources. So another framework that we want to know is yung stages of behavioral change. Very important to when we do counseling. So ito yung steps. I'm sure you've seen this before, pero this is probably the first time that you've seen it with a lot of memes. No, so I just wanted to be more relatable to most of us. No? So the first step is, so this helps us determine kung nasaan na yung client natin when it comes to behavioral change. No? It's very important so that we would know how to approach the counseling. No? So pre-contemplation is, for example, let's just give a situation wherein our client would want to use condoms more often. So nasa pre-contemplation phase siya when you talk to them and then sasabihin niya, hindi ako gumagamit ng condom kasi feeling ko hindi naman ako mahawa. No? So yan, yung cat meme na no, because no. Parang very close-minded. So next, contemplation. So napapag-isip-isip na niya. So siguro i-try ko na mag-condom next time. No? Tapos yung next, preparation. No? So kumuha na ako ng condom, ng libreng condom sa community center. Susubukan ko next time pag makikipag-sex ako. So yun na nasa preparation phase na siya, wherein yung next step is action. So sasabihin niya sa'yo, yan, gumamit ako ng condom ko the last time I had sex. No? The very important stage is always the maintenance. So you will always hear Lufa may Quinto in your head, no, go lang ng go. So parati na akong gumagamit ng condom. No? Pero there's always a risk in any stage of behavioral change. There's always a risk of relapse. No? So hindi mo na ako gumamit ng condom kasi hindi ko bet. No? So yeah, babalik siya dun sa stage 1. No? So very important kasi we would know how much support we will give to the client. But this this guideline from FHI is very specific to HIV, no, and would be very helpful for us to give concrete steps on what we can do. So it's divided into 2 sections: initial assessment and follow-up visits. No? So the initial assessment includes 8 steps rather. So firstly is the introduction and consent. So sa ating Philippine DOH guidelines, when you consent to HIV testing, you also consent to counseling. So step 2, assessing the client knowledge. It's very important to know if the client knows how HIV is transmitted. And then you eventually assess the behavior of the patient to understand which behaviors that the clients do to put them at risk. And then wrap up the assessment. So summarize my issues for them. You should clarify and correct some yung mga fake news and misconception, disinformation. Ako, maraming ganyan sa Pilipinas. Pero yun, yung misinformation and disinformation. Tapos, provide information. Step 5, discuss why behaviors put the client at risk. Kailangan niya maintindihan why yung behavior is putting himself at risk, herself at risk. No? So, and then assessment of motivation, very important, as we've seen in our frameworks and in the stages of behavioral change. Gauge the commitment. Ayan, yung may mga commitment issues. No? Prioritization setting of behaviors. kasi may mga competing interests din. Plan for tapos do a prioritized behavior. No? So always check natin which behavior puts them at most risk. No? So parang so parang 80-20 rule. No? So parang you change something big. You change a small thing and then it changes a lot of things already. No. Tapos next is to always list the goal so that you may always have something to look back after. Tapos in our follow-up visits, in step 9, we follow up yung support natin sa client. And then lastly is monitoring and evaluations just to check how the patient is going with their list. So we always have to remember that behavior change takes time, it requires commitment, it requires close follow-up. And it's very important for us to always remember to ensure the comprehensiveness of services and continuity of engagement is always the key. Okay. So for our last slide, I would want to come back to where we started. No? So there is no one size that fits all in HIV prevention. And as a provider in the primary care, when I was previously, when I was with Love Yourself, there are times na yung mga staff, would care for our patients more than we care about ourselves. But it's always good to remember that prevention is not just about PrEP, it's not just about PEP, it's not just about counseling, but really structural changes that we see in our society. So as we can see here, yung decriminalization, gender violence, yung mga issues of gender violence, yung laws and protection, interventions. So our jobs could have been easier, kung may SOGI law, or if yung mga PWID, walang senseless murder among PWID, so and yung mga services are easily accessible, and walang stigma, walang discrimination, so our jobs could have been a lot easier if all of those things are in place. But mind you, in the work that we do in the primary care setting, I'm sure that it's not just providing PrEP, PEP, ARTs, counseling. It's also the advocacy that we do. That's very important. And there is no one size that fits all in HIV prevention, but all should have equitable access to whichever may fit them. So yun yung pinakagusto natin in what we do. That what's give our jobs meaning is to fight and to advocate for a better living conditions of our patients, of our clients, and so that they won't be suffering from these health disparities. So, I just wanted to emphasize that. So, thank you.